Hey, you know how a nurse tells you before she gives you a shot, it's gonna sting a little? And you think that by her telling you, it might help the situation, but it doesn't. It still hurts like the dickens. Well, I need to apologize for the acoustics and the sound in some of the clips in my home office. We just updated it. We're still trying to figure out the acoustics in there. So, it's gonna sting a little, but it's for your benefit to watch this video. In today's video, we're gonna pretend as if Chadwick Boseman presented as a patient to my ER and how what eventually led to his death was abnormal. Please consider subscribing, hit that bell notification, and I hope I earned some of your time and your attention. So let's do the dang thing. Let's learn, let's laugh, let's do this. Knuckles, noggin, butterfly kisses, squeaking. This video finds you facing whatever stressors and challenges you have in your life with full force, with broad shoulders, and with it just a strong belief and a hope that you can overcome it, because I know you can. This past weekend, we lost a man among men, Mr. Chadwick Boseman. He lost a 4-year struggle with colon cancer. My heart goes out to the family and loved one of Mr. Boseman. The more I've read about Mr. Boseman, the more I am positive that if I had ever the honor and the opportunity to meet him, I would have loved him. Who wouldn't have geeked out? I mean, the man was an inspiration. He was the Black Panther. The purpose of today's video is to use Mr. Boseman's illness as a tool to inspire and educate the life of others in really the only way that I know how, by sharing his message through uplifting medical education. As I began to read of Mr. Boseman's death, my mind went to his roles in the movies that I love, but I also began to have my medical mind on, and I couldn't help but wonder, what would have happened if Mr. Boseman would have walked into my ER? First off, you wouldn't know about it. Hello, HIPAA violations. But second, I would have been like, what are you doing here in the Midwest? As I began to read about Mr. Boseman's passing, I began to formulate this clinical vignette, this clinical case in my mind. What were his most likely presenting symptoms? What was he suffering from? What signs would let me drive one direction versus the others? What tests would I order? From some of the information that we can gather from the statements released by family, we know that he was a 43-year-old black man that died from complications of stage 4 colon cancer. Going forward, we will refer to this patient as CB. He fought this battle for over 4 years. So that means 4 years prior, he presented with some symptoms at some location. So if we use that as our starting timeline, we can roughly assume that a 38 to 39-year-old black man presented to a primary care provider or some location such as an emergency room with symptoms. Now, the thing that I found most immediately interesting about Mr. Boseman's case and how he may have presented to an emergency room was his age. Mr. Boseman died at the age of 43 years old. And that will play an important role in as we discuss this process. Now, if CB followed the most common presenting symptoms of those that are eventually led to have a diagnosis of colon cancer, he may have presented with symptoms such as weakness and fatigue, changes in his bowel function, including constipation or looseness of stool and diarrhea. He could have had abdominal pain. He could have had evidence of rectal bleeding. He may have an unexpected weight loss as part of his symptoms, but these are not exhaustive presenting symptoms. From personal experience, I have had many patients present to my ER that eventually were diagnosed with colon cancer, and their only presenting symptom was they were a little lightheaded. Or that when they went to the bathroom, they still had the sensation that there was more there and they could never get it all. The next step of the process is the triage, the workup. The nurse would then gather the vitals, okay? Medical vitals come from the Latin word vitalis, which means life. These are the markers that we use to assess a patient's acute illness. How seriously sick are they? Based on those vitals, and if they're within normal limits, or if they are high or low than what we typically would like to see, it raises our focus towards that patient as a patient that might need quicker and more focused care. Those vitals are your temperature, heart rate, respiratory rate, okay, your oxygen saturation or O2 levels, and your blood pressure. Any one of those in a presenting patient that would have colon cancer could be off, or it could be completely normal. With this information, then I would then conduct a thorough physical exam, head to toe evaluation with a more focused effort in the area steered by his chief complaint. With now chief complaint, a history provided by the patient, we have vitals, and we have an absolute excellent physical exam. Now we go on to our differential diagnosis list. A differential diagnosis list is an exhaustive, over-the-top list of absolutely every conceivable possible cause for this patient's presenting symptoms. Once you make this exhaustive list, you begin to narrow it down to the most likely based on initial labs returning patient symptoms, experience. So as CB presented with these symptoms, I would begin this thought process. As I'm practicing medicine in the ER, oftentimes there's no real sit down, make a list. It is a running list and a running differential in your mind as you're asking questions, as you're doing the physical exam, so that by the time you leave that patient's room, you have marked off a vast majority of that list. And you've kind of honed it down into a top 3, maybe 5 most likely diagnoses. To further whittle down this differential diagnosis, we need more information. And how we gather that is through labs and through advanced images. Main options are X-ray and CT. Most physicians with these presenting symptoms are going to get a CT abdomen. Basic labs are going to be CBC to help us determine how much blood he's lost and if he needs blood products to be replaced. A CMP is going to help us understand if there's been kidney disease, if there's been liver disease, if his electrolytes have been lost from this vomiting or diarrhea that he may be having. Each result I get back is another piece to that puzzle that is Mr. CB's presenting illness. Now, as I'm whittling down this diagnosis differential of Mr. CB, cancer is on the list, but I just can't or won't or wouldn't want to believe it because of his age. Now let's take a sidebar about why I found Mr. CB's age so interesting and abnormal. Association for the American Family Physicians and the American Cancer Society both recommend for normal risk individuals to start screening for colon cancer at the age of 45. At the time of death, CB was diagnosed, as previously mentioned, with stage 4 colorectal cancer. Previously, 4 years ago, he had stage 3. So when he was first officially diagnosed, it had already advanced and progressed to the level of stage 3 at the age of 39. Well before any physician would have considered doing any type of fecal tests or any type of colonoscopy to determine if he had any evidence of colorectal cancer without symptoms. With individuals that have a higher risk, specifically they have a primary relative, a father or a mother or a grandfather or a grandfather that have been diagnosed with colorectal cancer at a certain age, it is recommended that that person begin screening for it 10 years prior to that relative's age. So because by the time Mr. CB had the diagnosis of stage 3 colorectal carcinoma at the age of 39, I can only believe that he was considered a normal risk individual. He did not have any significant close relatives that had colorectal cancer that would have indicated an earlier screening to find this at an earlier stage, which flat out sucks. And it sucks because the lack of symptoms and his young age led to a delay in his diagnosis, which led to a delay in his ultimate treatment. But this does not mean that any physician or healthcare provider missed anything. The age and the symptoms most likely were just not there in his favor. So at this point, if CB was at my ER, he had the labs, he had the findings on CT that showed concerning findings for colon mass, he would then be discharged depending on his symptoms, his severity, or admitted to the hospital with a GI consult, most likely for a colonoscopy with the intention of biopsying that mass. That biopsy would then be sent for microscopic analysis to determine if it was cancerous or not. This would then lead to additional tests to determine if that cancer had spread, metastasized anywhere, and then oncology would be involved to determine the appropriate treatment options. While I do not know the specifics of his treatment, we do know that he fought it for 4 years. And through that 4 years, it progressed from the stage 3 to the stage 4 cancer. If we take a quick sidebar and go to cancer.net and look up colon cancer staging, we'll be able to see the specific things that pathologists use, what's called the TNM staging, tumor, node, and metastasis staging system. These are the guidelines that helps these individuals stage the degree and growth and spread of cancer. So initially you'll see this stage 1, stage 2. This is when we have evidence of a mass but no metastasis to local lymph nodes or other organs. As we go to stage 3, you'll see metastasis to lymph nodes but without other organs. This is the stage that Mr. CB was at on initial diagnosis. He had most likely evidence of metastasis to a lymph node but no organs. Over the course of his 4-year battle, this advanced to stage 4, where there is metastasis to lymph nodes and metastasis to other organs. This spread eventually leads to an overall system organ failure, which ultimately took his life. By examining Mr. CB and the case that we just discussed, I want to stress the importance of establishing care with a primary health provider. It is important that you have some healthcare provider that is on your team, that is analyzing it, that is filtering through all these risk factors, all these symptoms, so that you can get the earliest head start on any ugly thing that might rear its head. As an emergency medicine physician, I am frequented by death. It often comes unexpectedly, but I find it one of my greatest privileges in practicing medicine to participate in that moment with the patient and their families. To share such an intimate and personal moment with that patient and with the family is beyond an honor. Again, my heart bleeds for the family of Chadwick Boseman. I am sorry for your loss, but I hope that we can honor your life by taking care of ours, by using this as an opportunity to educate ourselves about our own health, to take the necessary steps to screen ourselves and our family and our loved ones so that we continue to produce goodness for the world like you did so well. Rest in peace, CB.